And then we move to the not doing an axillary lymph node dissection. We have enough evidence from randomized trials. And the next move has become in the neoadjuvant setting, where we are doing sentinel lymph node biopsy. And in those patients with a pathologic complete response, we are skipping the axillary lymph node dissection. You can see how much has increased the use of sentinel lymph node biopsy after neoadjuvant treatment across all subtypes.
The International Society of Oncology Prevention and Treatment, or ISOPT, believes every adult deserves to know their cancer risk before cancer arrives.
We are going to move to the surgical part, and probably it's one of the areas of the pillars of treatment that has changed so much in the last decades, mainly in the neoadjuvant setting. These are my disclosures. So we know that there are many advantages of the neoadjuvant treatment. I'm not going to go into that, but just focusing on the surgical part, it has allowed us to downstage the breast surgery to breast-conservative surgery, to de-escalate the axillary management. And as we can see here, we have more and more early-stage breast cancer patients who undergo neoadjuvant treatment and head surgery. And the optimization of surgery has become an important and very impacting on patients, not only on oncological outcomes, but also on the quality of life. And we were looking into the next step in omission of some types of surgery in very selected patients. So related to the breast, I'm just going to focus on a couple of issues because there has not been so much advances or de-escalation like we do with the axilla. But I want to make a point that we don't need really to have a breast PCR to do breast conservative surgery. And we have data here from many studies looking into those patients that do not have a breast PCR but still undergo breast conservative surgery with very good oncologic outcomes. So this means that if they have a PCR, of course, but if they don't have a PCR, they can still have breast conservative surgery. And also we are using more and more minimally invasive breast conservative surgery, and we are very much experts in intraoperative ultrasound that we learned from Dr. Klimberg many years ago. And now we are using it, and in those patients who has a minimal residual disease in the breast or pathologic complete response, we can use the ultrasound achieving higher rates of negative margins and having better cosmetic outcomes. And if we can see, and this is data from the AXANA trial, that it's a prospective registry on neoadjuvant treatment that I will just present a little bit more later, but just to show you how the rates of breast conservative surgery has changed after neoadjuvant treatment in the last years. You can see that 2/3 of the patients undergo breast conservative surgery in the neoadjuvant setting in the real world data from 2020. So what about the axilla? Of course, you know, the axilla has become the most important topic in the de-escalation of surgery, just because we know of the comorbidity and the secondary effects of the axillary lymph node dissection. And you can see here that we have moved from axillary lymph node dissection in the 70s to every single patient with a diagnosis of breast cancer. We moved to the sentinel lymph node biopsy in the 90s, where we proved that there is no need to excise negative axillary nodes. And then we moved to the not doing an axillary lymph node dissection in upfront surgery in those patients with a positive sentinel lymph node biopsy. And you can see there that we have enough evidence from randomized trials. And the next move has become in the neoadjuvant setting, where we are doing sentinel lymph node biopsy, and in those patients with a pathologic complete response, we are skipping the axillary lymph node dissection. And this is data from the USOMA database, an European database from more than 50 certified breast cancer units across the world. And you can see here that if we compare two different time points of time from 20 2010, 2015 to 2016 and 2020, you can see how much has increased the use of sentinel lymph node biopsy after neoadjuvant treatment across all subtypes. Of course, now we know that doing a sentinel lymph node biopsy in those patients with a clinically negative axilla after neoadjuvant treatment is safe and is accurate. And we have data there with regional recurrences very low in long-term follow-up. So what about those patients with a clinically positive axilla before neoadjuvant treatment? And you can see how the type of surgery has changed in the last years. We are not only doing axillary lymph node dissection or sentinel lymph node biopsy, we have incorporated another two ways of doing the surgery, and is the TAT procedure and the targeted lymph node biopsy, where we just put a marker in the node and excise that node, or the targeted axillary dissection, who implies marking the node, excising that node, but also doing a sentinel lymph node biopsy. And this has changed completely the way we do axillary surgery after neoadjuvant treatment and also in upfront surgery. So we have many data already on those patients after neoadjuvant treatment with a clinically axilla that we just use the TAT procedure. And as you can see here, using different types of markers, different like black ink, using clips that can be seen under ultrasound, using magnetic seeds, radioactive seeds. Everyone can use a different type of marker depending on the resources that they have in their institutions. But what is important is that the false negative rate of the sentinel lymph node biopsy and the targeted axillary lymph node dissection is in the majority of the cases below 5%, that it is a really good number. So what do we know with those patients who has a clinically positive axilla undergo neoadjuvant treatment and has a complete pathologic response? And it's managed by sentinel lymph node biopsy. Do these patients need an axillary lymph node dissection? Of course, we have mainly retrospective data, and you can see here all the studies from the retrospective data showing that there is no significant differences between doing an axillary lymph node dissection or doing a sentinel lymph node biopsy or a TAT procedure in those patients, meaning that even this is retrospective. Those patients who have a clinically positive axilla compared to complete pathologic response in the axilla do not benefit from axillary lymph node dissection. But we also have not only retrospective data, but we have data from the AXANA study that it's a prospective registry study, international. We are part of the Spanish group incorporated in this trial. And this prospective registry is looking into those patients with a clinically positive axilla who undergo neoadjuvant treatment. As you can see, the primary endpoints is axillary recurrence-free survival and invasive breast cancer-specific disease-free survival, also looking into quality of life and mortality. So when we compare axillary lymph node dissection versus sentinel lymph node biopsy or TAT procedure or total lymph node biopsy, you can see that the 3-year axillary recurrence-free survival has no significant differences between whether we do an axillary lymph node dissection or a TAT procedure in those patients with a positive axilla who become a complete pathologic response in the axilla. Meaning that, as I mentioned, this confirms the retrospective studies showing that we don't really need to do an axillary lymph node dissection in those patients because this is oncologically safe. And of course, the reducing in the rates of lymphedema are clear without the axillary lymph node dissection. We also have this dilemma and this discussion that I think it's no longer needed, whether it's better to do a TAT procedure marking the node or just a sentinel lymph node biopsy, where the majority of the studies has shown that it doesn't matter as far as you are expert on that and you have your own data related to false negative results, whether you use a TAT procedure or a sentinel lymph node biopsy, as you can see here. the axillary recurrence at 3 years and the invasive disease-free survival is the same in both groups. So there has been also this discussion on whether those patients with 1 to 3 positive nodes or more than 4 positive nodes clinically before neoadjuvant treatment can undergo the same type of TAT procedure, sentinel lymph node biopsy. And this is also data from the AXANA, and it was presented in ASCO this last month. You can see that with more than 5,000 patients, and you can see that mean age, 54% of pathologic complete response, and you can see that around 22% of the patients has more than 4 suspicious nodes on the diagnostic staging before neoadjuvant treatment. And what they found is that in the multivariate analysis, there was a higher axillary PCR rates, only depending on the Ki-67 that was higher than 20%, on the receptor status, mainly in those triple negative breast cancer and in those HER2 positive breast cancer, and those patients with higher grading, but the initial number of suspicious nodes was not associated with axillary response. So meaning that in those patients with a node-positive breast cancer, tumor biology, rather than the extent of nodal involvement, as far as they are clinically N1, predicts axillary response to the neoadjuvant treatment. So I think that the discussion about if there are 3 or 4 or 5 suspicious nodes before starting the neoadjuvant treatment can be concluded with this prospective study. So what about radiation therapy? How things has changed in the de-escalation or the optimization after neoadjuvant treatment? Well, we have the results already from the NSABP-B51 that was presented 1 year ago. In those patients undergoing neoadjuvant treatment, whether mastectomy or lumpectomy, and they were looking into the impact of regional lymph node radiation therapy in those patients who undergo a complete axillary and complete pathologic complete response. You can see here almost 2,000 patients, 5-year follow-up, and you can say that when you look into the invasive breast cancer recurrence-free interval or the disease-free survival, there is no significant differences between those patients who has irradiation to the axillary nodes or not in those who had a PCR. So meaning that in those patients with a clinically positive axilla who develop a pathologic complete response after neoadjuvant treatment, regional lymph node irradiation did not improve any of the oncological outcomes, meaning that probably this is a group, high-risk group with very good oncologic outcomes who can skip radiation to the nodal basins. Of course, you know, there are always limitations, and I was talking to the radiation oncologist. They always, I don't think this is still put in clinical practice in many of the institutions because they feel that the follow-up is very short, 5 years follow-up. And they also look into those triple negative breast cancer that there are some data that there is a high local recurrence with the omission of the regional irradiation. So still we are waiting to implement these studies, but I think that in those patients who had a complete pathologic response in these high-risk groups, many of them will benefit from the escalation, the axillary radiation therapy. So what about those patients with a clinically positive axilla who has still residual disease in the axilla after the neoadjuvant treatments? Do those patients need an axillary lymph node dissection or not? Well, we have data from retrospective studies, as you can see here, showing that probably not. The majority of them will not benefit from axillary lymph node dissection, even though in the micromet study, there was a group that it was the triple negative breast cancers where the lack of irradiation to the axillary nodal basins and the axillary lymph node dissection could make a difference in oncologic outcomes. Retrospective data, we still don't have enough data in the prospective setting not to do an axillary lymph node dissection in those patients who still has residual disease in the axilla after the neoadjuvant treatments. And as you can see here, this diagram, in those, what I've been telling you, in those patients with clinically positive axilla and still residual disease in the axilla, we probably need to wait from more data on the Alliance trial and the TAXI trial to stop doing an axillary lymph node dissection in these patients. In the rest of them who develop a complete axillary response, complete pathologic response in the axilla, you can see that you can apply the NSIBP 51 or also the RAPSTAM trial, who is a trial from the Netherlands to skip axillary radiation. So what is the next step? The next step would be omission of surgery after neoadjuvant treatment in selected patients. So where are we with the studies here? Well, we know about the study from Henry Currer from MD Anderson, looking into omission of breast and axillary surgery in very selected patients, HER2-positive triple-negative breast cancers. And you can see that the primary endpoint is ipsilateral breast recurrence-free survival at 5 years. There is no recurrences in this group. Very selected patients, very important the way they do the assess of the residual tumor after neoadjuvant treatments in terms of the imaging, in terms of the vacuum-assisted biopsies to get these results. As far as I know, they are working on a randomized trial to put this in practice, because as far as now, we still don't have enough data to omit the surgery in those patients if it's outside of a clinical trial. But the story continues with the sentinel lymph node biopsy, and we will see in the next couple of years data from omission of the sentinel lymph node biopsy after neoadjuvant treatment with some of the studies. The UBRES study, where we are part of this, is a European study looking into omission of sentinel lymph node biopsy in triple-negative and HER2-positive breast cancer patients who has a radiologic complete response before surgery and a pathologic complete response in the breast, because we have seen that in those patients, HER2-positive and triple-negative, clinically negative axilla before neoadjuvant treatment, who has a pathologic response in the breast, this is significantly associated with a negative axilla. So the study is already closed. It was closed on December 2025. So we will have some results by the beginning of 2028. But we are not the only ones. The group from Korea with the ASLAN trial also completed accrual. We will have also some results in the next couple of years. And the optimistic, who is still recruiting, also from South Korea. Very similar group of patients who are included. As you can see, the majority HER2-positive and triple-negative. And we will have results in the next year. So probably by 2030, we will have very selected patients where we can skip a sentinel lymph node biopsy or a breast surgery after neoadjuvant treatment, who are excellent responders. There are also some studies open or recruiting. One study from China and the Neonautilus also from the Korean colleagues. And then also we will need to see, because we are de-escalating the surgical part to reduce secondary effects and improve quality of life of patients, mainly in terms of the lymphedema rates. But what about the radiation therapy? And this is also a study from the MD Anderson, looking into those patients who are excellent responders, if they can eliminate breast cancer radiation therapy in the neoadjuvant setting. And you can see here how the study is going on. So what is coming next? So coming next is that we are doing surgeries less invasive, more targeted, and also tailored to the individual patient needs. So we will see that breast cancer surgery will achieve similar rates as the upfront surgery after neoadjuvant treatment, something that we haven't seen 2 decades ago. We know that sentinel lymph node biopsy will become very selective and will not be routine in every single patient with a breast cancer. Axillary lymph node dissection will keep decreasing over time. And we will have to find a way to teach our residents on how to do axillary lymph node dissections, because it's a surgery that we do less and less, because we have seen that in many cases there is no benefit in oncologic outcome for the patients, and the quality of life really increase when we don't have an axillary lymph node dissection. We will see which patients we can omit a sentinel lymph node biopsy and a breast surgery after neoadjuvant treatment. And I think this will be the group of the triple negative and HER2 positive breast cancer patients. And probably in a way, in some patients, the axillary surgical staging can be just surpassed by the genomic profiling to guide treatment decisions. In some of them, also in selected patients, we will be able to see that too. So thank you very much, and looking forward to the next of the meeting. I just want to invite you to the next ESO Congress in Madrid in November. Thank you.